All right. Well, thank you so much, everyone, for joining us today. We are thrilled to see the turnout, and we are so happy that you took time this afternoon to join us for this panel presentation. My name is Dr. Sheila Vicaria. I'm the Deputy Director of the Department of Research and Academic Engagement at the Drug Policy Alliance. The Drug Policy Alliance is the nation's leading advocacy organization working to fight and end the war on drugs and advocate for policies grounded in science, compassion, public health, and human rights. We are thrilled to be co-hosting this event today with Filter Magazine, a nonprofit harm reduction journalistic outlet. For more information about Filter, you can look them up at filtermag.org. So before we get started, I just wanted to highlight a few events that we have coming up that might be of interest to you since you are joining us here today. So I'd like to flag that we are hosting a webinar next week. We are hosting researchers from the Global Drug Survey to speak about some of the preliminary findings of their COVID special edition survey that they conducted early on during the pandemic. And they'll be talking about some of the preliminary trends that they found in terms of drug availability and drug markets and a variety of other factors. They'll also just be talking a bit about some of the challenges and opportunities of doing survey-based research in light of the pandemic. I also want to highlight that we've already scheduled our next September Drug Researchers Roundtable, and we'd love for you to join us. Please note that it's not at the same time as our usual Drug Researchers Roundtable. It's actually going to be Tuesday, September 29th, but during the regular time of 4:30 to 6 p.m. We're actually super excited to be hosting Maya and Victoria to speak about their latest book, that has received tremendous accolades already, Prison by Any Other Name. So we hope that you'll be able to join us for that event. So as we get ready to get started today, I just want to remind you that we would be thrilled to have you live tweet this event and to highlight any of the lessons that you've learned or any key quotes or anything that comes to mind relating to this event today. You can use the hashtag DrugResearchersRT. And each of our lovely panelists is on Twitter and would love to be tagged and followed if you so choose to do so. So as we get started, I just want to briefly introduce our speakers today. We have Dr. Pooja Lagasetti, who is an assistant professor at the Division of General Medicine in the Department of Internal Medicine at the University of Michigan, Ann Arbor. We have Helen Redmond, journalist and senior editor at Filter and a documentary filmmaker. She's also a fellow social worker. We are incredibly privileged to have Laura Shaver with us today, president of British Columbia's Association of People on Methadone, and Louise Vincent, the executive director of the Urban Survivors Union. So thank you so much, ladies, for joining us today. And to kind of kick off the panel, given that we might have audience members with kind of a diverse background, some of whom may know more about methadone than others, I'd like to just take a moment to invite Pooja, Dr. Lagasetti, to just set the stage for us. Can you tell us what is methadone and what does it do? And why is it considered the gold standard medication for opioid use disorder? What makes it work so well? And can you talk a little bit as a prescriber and the differences between being able to prescribe methadone for pain versus for opioid use disorder?
Great, thanks so much for having me. So, right now there are 3 evidence-based treatments to treat opioid use disorder: methadone, buprenorphine, and naltrexone. And one of the reasons that methadone has been considered the gold standard is, one, it's been around the longest, and we've been able to use it to treat opioid use disorder for a very long time. And so we understand its efficacy, we have long-term outcomes around its success, and we know exactly how to dose it in order to help individuals. I would say that the simplest way to think about methadone is that it is a pure opioid, much like many of the opioids that we might, if somebody may take, whether that's a prescription pill like Percocet or Vicodin, whether that's heroin, fentanyl, etc. It works similarly and attacks the opioid receptor, head on in a complete way. The one thing that it does do, though, is it acts in a really long-acting way. And so instead of giving an individual like an immediate high and an immediate release, it lasts for a really long time. And so it allows somebody who might be suffering from cravings or withdrawal from other opioids to kind of, calm down the system and take an opioid to attack that receptor instead, and kind of stay calm and relaxed for a little bit longer than you would have with a shorter acting opioid such as fentanyl. The way that methadone has traditionally been dosed in the United States is that currently, in order to prescribe it for opioid use disorder, you have to be using it in a specialty addiction treatment program. So what that means is that, a primary care physician like myself who works in an office-based setting, if I'm not working in a specialty addiction treatment center, I can't prescribe methadone for an individual who has opioid use disorder. However, interestingly, I can prescribe it for an individual who has pain. And there's very little difference. At the end of the day, it's the same medication. It's just being prescribed and potentially dosed in a different way. So methadone at specialty treatment centers often is dosed in a liquid format. It's given daily. It's often dosed in a liquid format because it can be really titrated quite well with respect to kind of milligram dosing in the liquid format, but it can be given once daily at these specialty treatment programs. In comparison, when it's used or treating individuals for pain, it's often dosed 3 times a day in the form of a tablet. But there's there's no difference in the actual drug that's being used in these 2 different scenarios. And so this restriction on how we can prescribe methadone and for whom it's legally able to be prescribed for has made it so that it's highly regulated and can only be accessed in certain centers, which aren't really available in multiple places. The other things that regulations do, I think, that are important to know is that currently in a specialty addiction treatment center, you're supposed to really be dosing methadone, at least in the United States, on a daily basis. You can, each of these specialty treatment centers can allow for some, quote, take homes. So that means that once an individual has, shown that they can be maintained on a certain dose and are taking it regularly, they could potentially take a couple of doses home before they have to come back into the specialty treatment center. But otherwise, in most treatment centers, you do have to show up every single day to get your medication.
Thanks, and that really that's a really great overview, and I hope that for folks who needed to be brought up to speed, they picked up a few things. And it sounds like Laura also learned a little bit about what we do in the US. So in a few moments when we invite you to chime in, we'd love to hear the contrast of what's happening in Canada. But I'd like to take a moment for a second to invite Helen on board right now. Can you talk a little bit about how the war on drugs, frankly, has played a role in why methadone is treated so differently compared to other medications that we currently use for a variety of other health conditions and disorders?
Can you say DEA, Drug Enforcement Administration, has a central role in how methadone clinics were organized and how they function today. And the DEA is a policing organization. They are charged with leading the war on drugs. They're drug warriors. And the fact that they're involved at all in the provision of methadone is just, it's stunning. In other countries, methadone is overseen by the Ministry of Health or public health agencies, but not a policing organization. So that is something that has an impact all the way down to everything that happens inside a clinic. And so the DEA, and there's other partners, there's SAMHSA. So it's a group of people who have put this together with the DEA, I would argue, at the top. And they've created what many people that I've talked to who are on methadone consider it has a lot of carceral elements where it's people have told me it feels like they're in jail, they're in prison, they're on parole. These are the words of people on methadone. They're not my words. And if you just look at the barriers that have been built into the system, attendance requirements, Dr. Legacetti just talked about that. Imagine going somewhere 6 days a week to get your medicine. Imagine that. Imagine that right now in Texas and Louisiana, where they're being hit by a hurricane. traveling to a clinic 6 days a week. In rural areas, some people might drive an hour, 2 hours one way to a clinic. Think about how that impacts your life and your financial situation. So attendance requirements, travel requirements. That's why those are some of the reasons I believe the rate of people leaving methadone is almost 50%. I mean, how do you sustain that? And let's talk about the fact that we have had an opioid-related overdose crisis for over a decade. The DEA is in charge. Why hasn't that number dropped? One of the reasons is because it's very hard to access methadone and to stay in treatment. And that is criminal, that we have not expanded methadone to meet this human tragedy. It's really outrageous to me that the DEA has essentially no interest, right? We can't have methadone vans. It's only because of a pandemic, COVID-19, that some of the regulations were relaxed so that people can get 14 and 28 days. It took a pandemic, thousands of people dying for the DEA to loosen. Why did this happen 10 or 15 years ago? And from what I'm hearing from interviews I'm doing, I'm making a short documentary about the changes that have happened because of COVID. Why weren't these done before? I mean, why did we have to wait for this? So I believe that we have to get the DEA out of methadone.
Thanks so much, Helen. And I think you are opening it up for me to pass the mic now to Louise. Don't forget to unmute yourself. And I'd like for you, can you talk a little bit about what it's like on the ground in North Carolina right now as someone who takes methadone, who uses methadone and works with folks who take methadone? What are some of the challenges on the ground? What did it feel like for the changes to kick in supposedly post-COVID? Was that a reality where you were? And can you tell us about some of the advocacy that you've been involved with in light of some of these changes?
Thank you, Sheila. I sure can. And Helen, thank you so much. That was great. I'm always grateful for people out here fighting for methadone reform. So on the ground in North Carolina, and on the ground like everywhere that we're hearing, because we have a national union that we have people like weighing in from all over the United States. What we're seeing is continued barriers. It took a long time for even any regulations to be relaxed in many clinics. A lot of clinics you now can't get enrolled, so they're not taking new patients, or they have reduced the amount of days that it takes to get so you can enroll on 1 day now instead of 5. Which is really problematic because you know what time we enroll? At 5:30 in the morning. And so if you oversleep for 5:30 in the morning, I really want to bring it down to what it is to a person's life that is in chaotic use with a drug supply that's poisoned and they need help. And then they oversleep on Wednesday, which was the day they needed to get to the doctor. So now they have 7 more days. And 7 days is too many. 7 days is too many when we have a poison drug supply and we have drugs on the market. We don't even know what they are, so we have stronger drugs than fentanyl. We know from reports, we know from the work we're doing in North Carolina, we know that while every other drug has reduced in quality, stunningly, opiates have increased in quality. So we have stronger drugs than we've seen prior to the pandemic, which is mind-boggling to me. I don't even understand how it's possible. So, but that's an aside. So we've got people that are really in need of getting into clinics, unable to get in clinics. So then many clinics did shut down for the weekend. So they would say, okay, so where you had to come for 7 days, now they're closed on the weekends. But the problem with this, which would be really great, right? The problem with this is that if you don't have the money to pay for the 2 days, they won't give it to you. So they won't let you make it over the weekend. So we have, 50% unemployment? We have people that are working in service economies, people that make money being waitresses and this kind of employment, right? No longer employed, no money, and now they have to have the money to pay upward of $14 to $16 a day. And if they're getting buprenorphine on a daily dose, that can be up to $30 a day. for one person. We're talking about having money ahead of time. So why would we not, why would they not relax the requirements so that you could pay at least on Monday when you come in? So people are not able to even have their weekend doses, and then they can't go in on the weekend because they're not open. So all the things that have happened seem to benefit the clinic, which is always the case. So any changes that they've actually made are helpful to the clinic and the clinic staff. They're not helpful to the people that need the medication. And there's a culture of cruelty and a culture of, you just sort of come every day and we just remind you you're, we have continued drug testing that was supposed to stop. All of these things that was supposed to be relaxed, we've almost gone completely back to normal now. They've pretty much, there was never any real social distancing. I don't care what anybody says, like, packing people in small buildings is not social distancing. And yes, they did reduce the amount of people. But when you have hours of come between 6 and 8 a.m., and that's, and the smaller the place is, the shorter and tighter the hours are for people to come in and dose. And so all of these are not only barriers, they're continued sort of, it's a continuation of the same old thing. And some clinics did do better. So I hear that while some clinics have extended the amount of take-homes to the 14 and 28 days, they did give some people those doses. But people that had any active drug use or were testing positive for any drugs, not only did they not get take-homes, when they stopped doing drug testing, if they stopped doing drug testing, then they couldn't get take-homes. So it really created an environment where some people benefited, but the people that are at the greatest risk and in the highest amount of need are once again the people suffering. And so I just had the news here not an hour ago talking about an overdose crisis in Greensboro. Surprise. We could have told them, we could have told them this, that we have more people dying now than were before. We are in crisis here, and our methadone centers and our treatment centers aren't doing everything they can fucking possibly do to get people in and get people on board and get people dosed up fast enough and quick enough. The slow uptake of getting yourself, moving from 25 to a stable dose. We're still removing people. We're still punishing people with their dose. If you don't have the money, then you can, like all of these things that we do to people that are so punitive and so despicable, and discrimination, to be quite honest, like we are continuing to do. And so Urban Survivors Union, we wrote a letter. We had over 100 signatories. It was really amazing. We had, it was the first time a national drug user movement, and it was the first time directly impacted people for real. Like a lot of times we have groups that are like, well, we represent directly impacted. It was the first time directly impacted people were at the table talking about what they needed to stay alive, right? And what they wanted and what needed to happen. And I have to say the response was enormous. And the people that signed on to this document were amazing. And we didn't realize we had the support that we had. And that is a testament to the hard work that we're doing and other folks are doing in this community, and what can happen when we come together. And basically, it's like Helen said, it took a global pandemic, right? It took a global pandemic to ask that you don't discharge people for anything other than like physical injury. Like we shouldn't be discharging people because they're using drugs. That's a ridiculous reason to judge. If I come to you and I say, I can't stop using drugs, and then you discharge me for using drugs, I don't know. I've never been able to figure it out. But, it doesn't seem like the way forward to me, and it doesn't read like the science says. So basic stuff like that, using telemedicine. Like, why can't we, and that was never fully implemented. But we were calling for, like, why can't we do our counseling through telemedicine? Why can't we do some of this through telemedicine? Why do you have to see us? Why do we have to be here? And I've been to a million webinars that really show how it could work in a really amazing way, that like stuff I would have never thought about. Like it can still be just as involved in your life through the camera. So like there's just so just asking for simple things, asking for the expanded for the expanded take homes. this is something, we're in a pandemic. Like it sends a really loud and clear message to people that use drugs that they don't matter. When people are dying and they're saying, stay at home, don't go anywhere except you go, even though you're, even though you're living with your grandmother and if you've got emphysema, you should go and you should pile in this building every day. So it sends a really loud and clear message that you don't matter. And when we wonder why people don't believe that there's a pandemic or don't believe that there's a public health crisis, why don't we try? Because you didn't treat us like there was one. So our letter called for some of that, and we have more stuff coming, right? So we have and part of our letter was also, hey, we know there's a pandemic, but we are still in an overdose crisis. And that's what we're seeing, right? We are still in an overdose crisis. It never ended. Our community's been in crisis, for years now, and we can't do this. I can't go back. We were just starting to make some gains. We just can't. We can't go back to just the daily death and the death toll that was so enormous and so overwhelming. I pray that our communities and our doctors and our social workers and our health directors and all of the people that give a shit will make sure that we don't go backwards, because we just can't afford to. We are losing too many amazing people, and there's no reason for it. This is so it's really not that difficult. It doesn't seem like it to me. So we've got more stuff coming. We've got a methadone manifesto coming out. We've got we did a survey where over 500 people responded, and we're going to be putting out a white paper that really talks about what does it look like on the ground? What happened? Did people get these extended take homes? And so we have a lot of really great results. We're just going through the data now. We're so excited about it. And so Urban Survivors Union is really glad to be, at least at the table. This is what we've been asking for a long time. Just have us at the table. And so we're grateful to be here. And thanks, Sheila.
Thanks so much, Louise. And I'd love to take a moment now to transition to BC and to invite Laura to talk a little bit about what does methadone advocacy look like in Vancouver in light of the ways in which methadone is being dispensed there, and what are some of the challenges that you've been facing, and what are some of the changes that you've been advocating for?
So I guess we see an extremely different scene, and it makes me feel grateful, but it doesn't. So we can go to any type of pharmacy and pick up methadone. The only ones where you have to go to special clinics are for the special injectables, because we have injectable programs here where you can get morphine or hydromorph or Dilar, but the thing is that, I am with Louise in saying that it took a pandemic, though, for these things to happen. This month, we had 177 people die just here. Maybe in the States, the numbers are bigger, but you have more people. But the thing is that, there are 11 people a day in Canada dying, which is an amazing amount of people. And when there's that many people dying, it hits so close. And, I feel the same way, is that it feels like, okay, so these people deserve to live and these people don't. The social distancing and has not happened properly here as well. They only just yesterday made it mandatory on buses to wear a mask, which means that, it puts people in danger. And the thing is that, yes, they have implemented changes for, okay, some people get more carries, some people, but the thing is that in rural communities, it's the same. They don't get, they barely even have a doctor that will prescribe. And then if they do, how are they going to get there? Maybe in one city, there's one doctor and maybe one pharmacy, or they have to travel 1 to 2 hours to get there, or, and it's, to me, it's outrageous. The thing is that these prescriptions are available. So why are they not being prescribed? And why is there why are there so many hoops to jump to get them? When I hear that, you can prescribe out there, if for pain, well, then people that are withdrawing are in pain, maybe not, physically and mentally. And that's the thing, is that, there are special clinics that we go to be prescribed. Here's some, but you can also be prescribed through doctors. And actually right now, they've made it so that some pharmacists can actually prescribe for you. So there's a lot of video prescribing or telephone prescribing because of the social distancing, but it seems like that's only still open and available to certain people. If you don't know about it, or if you don't or if you're not, an activist or working, with people, then you don't know those things. And so you're going out every day risking yourself to take a medication that you both physically and mentally need. And most people that are on methadone or an opiate replacement have compromised immune systems as it is. So which means that now we're in a dual crisis. Not only is there a pandemic, but now there's also an overdose crisis that has been going on now in major time for at least since 2016, where at least 4 to 6 people a day are dying. The problem is that we know what the problem is and we know what can fix it. Quit doing webinars, quit having this meeting and that meeting. We don't need them. What we need is action. What we need is for you to take the data that you see every day and make it into reality. And the thing is that, people, it bothers me when people think about those people as well. Those people are you. People would be so surprised if they actually knew the people that are doing the medications or the people that are, quote, drug users or drug consumers. And I think it might change people's minds. Here in Canada, the overdose crisis has killed more people and kills more people a day than the COVID-19 does. So that, there's a pandemic. So then what do you call an overdose crisis, where people are trying to get a, quote, medication that is supposed to improve their quality of lives and stop them from using drugs? Even if that's the only way to make people see that it's a positive, is that then maybe they won't be breaking into your house or into your car. Why not make it so that they can take a medication and take it every day? And the thing is that being somebody going to a pharmacy every single day to pick up a medication, how are you supposed to have a, quote, normal life? How are you supposed to hold a job or run a family when every single day you have to get to a pharmacy or to a clinic to pick up a medication? To me, it's a no-brainer. I don't understand it. It's the reason why I do the work and the activism I do. I'm very lucky to be in BC and Canada and to have the activism that we have here, as well as the quote drug laws, because we have a lot more opportunity to fight for things. And yes, I'm sure if I looked out the window right now, there's police sitting outside probably hassling the people that are trying to that may be dealing the drugs. But that's the thing is that should tell them that the safe supply and the opiate replacement therapy medications are not working. There are things that are missing. And if we don't have those, then people are still going to do the same. If people would pay attention that it actually costs less to have somebody on an opiate replacement therapy like a methadone than it does to house a person in jail every day. If that's the only way to get people to listen, then that's what we need to tell them. Because the thing is that this is what will change without having people able to have their dignity. And, can you imagine what it feels like, those who don't use methadone, to stand in, say, like a pharmacy or a big shopping mall chain down there, and having people staring at you while you're drinking your methadone, drinking a glass of water behind you, and then a pharmacist asking you to open your mouth to make sure that you swallowed it. And you being there to stand, maybe you've been there since 8 o'clock in the morning, but because there's people that are, quote, not taking methadone ahead of you, you sit there for 2 hours and wait for them to be served first. How are you not supposed to feel stigmatized or prejudiced against?
So much, Laura. And I think that brings us to an important transition, right? I mean, Helen has been an outspoken person calling for abolishing methadone clinics for some time. And I have a feeling there's a number of us on the line who feel the same way. But, one of the solutions that we propose oftentimes is pharmacy-based dispensing as, a less stigmatizing, more accessible alternative. But obviously we can, if we hear you correctly, I mean, there's still this kind of observation, kind of this surveillance that's still entrenched in how it's dispensed. And Helen, can I invite you in to speak a little bit more about the dynamics of surveillance and, pseudo policing that a lot of people feel and experience when they do get dosed, and some of the things that have emerged from your research and your work as a documentary filmmaker covering this?
Right. I think the surveillance starts when you get within a block or two of a methadone clinic. And so what am I going to say I think holds for urban and rural? There might be some differences. So you get within a block or two of a methadone clinic and you see security, and they're there for a reason. They are telling people from the clinic to keep moving, right? They have a mandate to tell people that they're loitering and they have to leave the area. Montefiore has a methadone clinic, and they have a job description for the security person, and they're very clear in the job descriptions online that they are on patrol, they're patrolling the perimeter, and their job is to prevent loitering. And the job description also talks about once inside the clinic, the security guard's job is to police the waiting area. And they even say that the security person's job is to take the person up to the medication window. So the surveillance, the policing starts with the security that is hired in every clinic. And then once you get to that window, some of the speakers have alluded to this, there is a nurse, and you are watched as you drink the methadone, asked to open your mouth, lift up your tongue to see if you have swallowed it. It's absolutely humiliating to have somebody ask you this. They ask you to take off your sunglasses in some clinics so that they can look at your eyes. And so we've got security guards, we've got nurses who are performing policing and surveillance functions, and then we have CASAC, certified alcohol and other drug counselors. They are the majority of the counseling staff in clinics, but there's also our profession, Sheila, social workers and other kinds of counselors. So I'm going to add my profession into that mix. And so CASACs are, again, going back to Montefiore, and they're looking for CASACs, and they say very explicitly in the job description for the CASAC that you will be performing supervised urines. And so what does that mean in lay terms? You're going to watch somebody's genitals as they pee. And again, it's inhumane. I think it's unethical. I can't believe that happens. Like that would be your job, is to watch somebody urinate. So that's what CASACs do. They also, there's mandatory counseling in many clinics. And so for a social worker, the idea of mandatory counseling is just an oxymoron for me. You can't force people into counseling. And then they are forced in, and then can you really be honest? I know Louise would have a lot to say about this. Can you say I relapsed, or I'm using benzos, I'm smoking marijuana, and then will that person take away your take homes, right? So this notion of mandatory counseling is a really, really bad idea. I was just in another state, and I was in the waiting room waiting for the director of the methadone clinic to come out and talk to me. And I saw on the wall a very big sign that said, counseling, group counseling is not optional, exclamation point, exclamation point. And that if you did not get on your phone for your group counseling, that your take homes would be suspended. So counselors are policing that and punishing people if they don't call in for group counseling. Now, everything is wrong with that. Everything is wrong with that. I just want to say something about the staff. I mentioned some of them, the security guards, the nurses, and the counselors. And For me, the clinic system is a system of oppression. It's taking a medication that reduces harm, and it's creating harm where none exists. So who carries out those federal, state, local rules and regs? People have to carry that out, right? It just doesn't happen. So staff carries out these very punitive and coercive rules and regulations. So for example, you will have counselors say to people, you can't have your take-homes to go on vacation because you missed 7 counseling sessions. You cannot get your take-homes to go to your mother's funeral in another state because your talk screens came up for benzodiazepines. This is how staff is participating in the oppression of people on methadone. And we call it treatment trauma for a reason, because staff is traumatizing people when they carry out these very draconian rules and regulations. Now, I know there's some people on this call that are gonna be mad at me and say, you're just talking, you're so negative, Helen. So I'm gonna say this, there are many people in methadone clinics who care deeply about their patients. They're empathic, they go out of their way to help. One nurse in my documentary, he said, I love the patients, they're really good people. But here's the problem, because you're nice, you are still in a system that oppresses people. That doesn't change because you're nice to somebody and you see them as a human being. You are in a system that is forcing you to do things, and you are making a choice to carry out those rules and regulations that cause great harm to people. There's no way around that. So I just wanted to say that. The last thing I want to say is, I think that there are people who work in methadone clinics who don't have patients' best interests at heart. They get off on that massive power imbalance between staff and patients. And that's another central issue, a problematic issue with methadone clinics, that incredible power differential where there's a group of people who stand between you and your medication. You cannot access it until they give you permission and you have fulfilled a number of obligations, or given up the urine, or given up the piss, as some people will say. And I just want to tell you this really quick story. And I think it speaks volumes about what happens to some people who work in methadone. My student used to work in a methadone clinic, and there's medication windows. And when that door closes, that's it. You can't get in. Well, somebody was banging on the door, banging and banging, screaming, I need my medicine, please, please let me in. I need my medication. I was late for whatever reason. Well, the person smashed through the glass door, smashed it open. And I understand why that person did that. The thing that haunts me is that the person on the other side of the door did not open the door. What happens to people who work in an institution, a system, that you would not open that door and say, come in, let's get you your medication. You need this medication. What happens to people? And I think people get burned out, they become numb, and they don't see people on methadone as human anymore. And it's one more reason to abolish methadone clinics.
Thanks so much, Helen. And I'd like to take an opportunity to invite Pooja back into the conversation for a second, because Pooja actually wrote and co-authored a really seminal paper that many of us cite and reference in terms of really thinking through the way that race and class play out in access to methadone versus buprenorphine, which is another evidence-based partial agonist treatment that works for a lot of people with opioid use disorder. And I was hoping for a second, Pooja, if you would take a minute to talk a little bit about some of your research and some of your key findings, and one of the ways in which methadone clinics also lock in particularly communities of color into these extra surveilled kind of systems, and as well as low-income and poor people.
Yeah, thanks. I will say that, my team, along with a host of other researchers across different universities, there's been about 4 or 5 papers that have looked at this issue. And basically, because of the federal regulations around methadone and the way these treatment programs are run, and also the finances that go into these programs, some of them are certainly for-profit private entities, but a lot of them receive federal dollars as well. And basically what we've found, Helena Hansen's group in New York City basically found that methadone treatment programs were largely located in urban, lower income neighborhoods that were largely serving Black and brown individuals, in comparison to buprenorphine, which can be prescribed not only at a specialty treatment program, but also by a waivered physician or nurse practitioner or physician assistant in an office-based setting. And that buprenorphine in comparison is largely being prescribed to white individuals. And this is even after you control for situations like insurance. And so, we do feel like what we're seeing is that there's essentially a division in treatment based upon race, and also based upon income, because the other thing that we found was bup, over the last 10 years, since it's been allowed to be prescribed in an office-based setting, what we've essentially seen is that a lot of cash practices have popped up, and 40% of buprenorphine across the country is actually through cash-only payments. And a large proportion is through private insurance, and an even smaller proportion is due to Medicaid. And so what you see is that there's this kind of class division. And I don't think that that was unintentional. A really great paper by Hansen and her colleagues basically demonstrated that when buprenorphine was being, when they were trying to pass Data 2000 in Congress, and allowing it for, when they allowed the 8-hour waiver, which was at that time a leniency, to allow physicians to prescribe it in any setting. What they essentially, how they passed it was that they said that they wanted a medication treatment for the, quote, less hardcore suburban users. And we all know what that code stands for. And so, there's always been this kind of division in the way, addiction treatment programs have kind of thought about methadone versus buprenorphine, whereas methadone is for kind of the, quote, more hardcore user, the more urban user, the Black or brown user. So there's this racism built into it, versus buprenorphine, because you can take it home for a month at a time, is, and it can be prescribed in this nice private primary care office, is somehow the better treatment for, a white individual who's employed, for example.
Thank you so much. And I just wanted to take a moment to invite Louise and Laura to hop in and kind of reflect on both what Pooja and Helen kind of contributed, but anything else that's come up for you and kind of just thinking this through.
I just have to, oh, sorry. Go ahead, Laura. You go ahead.
I feel the same way, and I really, there are a lot of really, really good clinics and doctors, but there are so many that use the system as a tool of punishment. The thing is that it is a drug treatment program, which means yes, drugs could possibly be in your system, and most likely would be. Why would that be the reason you would be punished? Is that not the reason why they would want to try and accommodate you and help you stay on an opiate replacement therapy more? By punishing somebody for having a, quote, dirty piss screen is pathetic and sad. It's the whole reason why they got on to it in the first place. And it's Helen's documentary was actually even, I think even the title, it is a liquid handcuff. And they are the jailers and the guards, because the thing is that they do either make it or break it. It will be their decision at the end of the day whether you will get it or not. And to me, withdrawal means death, because if you are in withdrawal, then you seek either the drugs or the opiate replacement. And with a deadly, drug supply, and I guess also a deadly way to prescribe it, then it's almost certain death. And the thing is that if you are in this profession if you are not in this profession to help and to not stigmatize and prejudice, then you are in the wrong place. Why would you be somewhere to harm people? Why would you be somewhere to make sure that people are in pain and cannot have a better quality of life? When you say that in the US there are only certain clinics and only certain doctors that can prescribe this, then those should be the people who actually care, who actually give a shit whether you live or die. Excuse my language, I'm trying really hard not to swear because I have a really bad potty mouth. But the thing is that it bothers me. Excuse me, it's just like here with clinics. You know, I'm now doing a second class action lawsuit for people in BC because the thing is that before I was a drug user, I was born as Laura Shaver. That's who I am. A drug user is part of what I do. But the thing is that I don't understand how people can be like this. You're in that profession. Why did you choose it then? Did you choose it because you want to hurt people, or did you choose it because you want to give them a good quality of life?
Thank you, Laura.
Louise, please jump in.
No, I just wanted to say two things. Helen told a story that reminds me of what I think of every time I see somebody banging on the clinic door, or the times that I've had to bang on the clinic door, you know, because they close at 8:30 and so they lock the door at 8:25 and they want to have everything put up. And what is the difference, you know, what's the difference for your life if you get out of work 30 minutes late or if I don't dose, right? And so what I've heard from the security staff is that, you know, we need to learn to be on time. Well, I'm never on time ever for anything, on drugs or not on drugs. I'm an amputee, and you know, and so these are things that are real for me. So I'm a disabled woman that hopped into the clinic daily, you know, while I was waiting for my leg, like hop on one leg, hop through, and was forced to do UAs once a week. There's a mandatory 8 observed UAs a year in federal regs. I think, something like that. Once a week with no leg. I mean, fuck with a leg, that's bad too. But like we're talking about, just, there are days I don't go to the clinic because I don't want to take a UA. There are days that I don't go to the clinic because I don't want to because I can't get up. I stay, anybody that knows me know I work at 4 a.m. I work all of it. You know, I just keep different hours. I don't work on a 9 to 5 schedule. It's not when I work. And so being up on the weekends between 6 to 8 to make it in these little, so I have actually not had a regulated dose of methadone for so many years that it's absurd. And I actually, you know, earlier in this year, I was off methadone. It was the first time I'd been off methadone because I was put out of the clinic for traveling too much and I needed to leave my job. You know, this was what I was told, that my job was causing me problems and that I needed to put my recovery before my work. And so anybody that knows me knows that probably the reason I'm alive is because of my work. And it's what kept me alive after losing my daughter, and it's what gives me any kind of purpose. And so to say something like that to someone like me is like, absolutely, it basically shows that you don't know me. Like I've been at the clinic for 11 fucking years. Like, it basically shows that after all the, you know, the changeover in staff, all of this, you don't know me at all. You don't know anything about what I need, and you don't care what I need. And I have been the woman that has been at the door ready to break through the glass. And that is not who I am. I have never had to be hauled off by security anywhere, never had to be, I'm a pretty passive woman, but I have been in a clinic so goddamn angry that I have been pushed past when somebody has something that you need that bad and they have that much power over you and you see that they are enjoying every moment of keeping you from your medication, that is the most disturbing. That is the most disturbing situation to be in. That I think it's one of the saddest places that I've ever found myself in, when I continue to have to, you know, I had somebody say, well, why do you keep going to the clinic if they treat you so bad? Well, what the fuck am I supposed to do? You know, I'm one of these people that buprenorphine is just not going to do it. Like I've been on a lot of drugs for a lot of time, and methadone is why should I have to be on buprenorphine? Methadone works. It's done really well. I made it through graduate school on methadone. Like why should I have to change? Why should I have to find a way to accommodate a system that, you know, I have more privilege than most people, and I can't find a way to get a regulated dose at a methadone clinic, and that is fucking sad. I'm an activist. I have I have a car. I have all of these things that other people don't have, but yet I'm not on a regulated dose. And there's a letter in my computer that says if I die, this is, if I die because of these things, it is the fault of the clinic. Because I believe that. I believe that while this is happening, if I can't be okay, it is the fault of the clinic, because it is not that I haven't tried. I mean, I'm not even allowed to talk in the clinic because I am apparently bad for people. So I'm not even allowed to say anything while I'm in the clinic, or I'm not allowed to be there. So I mean, these are the kind of things that I hear. So I just, when you're thinking, or when you're thinking of Helen's story and this person breaking through the glass, that's me. That's me breaking through the glass. That's me so goddamn angry. That's not just some, it's any one of us. It's what any one of us would do for people we loved. It's what any one of us would do for ourselves if we were in that situation. Thank you.
Thanks. And Laura, can you jump in and talk a little bit about how COVID has helped? And you spoke a little bit about this, but can you explain what safe supply is? What some of the efforts were among drug user activists in British Columbia, in Canada, and what you were asking for and what you received and what it's looked like?
Okay, so I also work with the BC Center on Substance Use, and they helped us write a safe supply guideline. So safe supply is, quote, supposed to be the replacement for the toxic drug supply. So they have now prescribed either you can get hydromorph, so Dilaudid, morphine, as well as either Ritalin or Dexedrine for a stimulant replacement. But the thing is that these are all good in that. But the thing is that what the health professionals see as a safe supply replacement and what our safe supply actuality replacement would be are two different things. Giving somebody a pill to replace smoking rock or smoking crack is unrealistic. I was prescribed Dexedrine, which is a pharmaceutical methamphetamine, and I don't use crystal meth. It's not the same thing. The thing is that, we safe supply is supposed to be able to also coincide with your methadone. So you take that as an opiate replacement, but are also supposed to be able to be prescribed the other opiate replacements that you want, and which includes different injectables. And if you do get prescribed injectables, you do have to go to a clinic. You do have to go in there and sit for a certain time. You do sit in a booth and do the injection, but it's still some place that you have to go to every day. It has been actually because of the pandemic that these things have come through, which means we've had different regulations now in our pharmacies, as well as now we're allowed to get deliveries for a very long time. I think it's since 2010. Deliveries changed where you could only receive deliveries if you were pretty much bedridden. In other words, if you weren't, then you had to make it to a pharmacy every day unless you had a consecutive of 2 months clean of urines, either on a call-in or a scheduled one. And that's the thing is that, even if you're on an opiate replacement, and if you're clean of opiates, but you're still doing a stimulant, you're not eligible for a carry, which to me is ridiculous because I'm on an opiate replacement therapy program, not a stimulant program. I will never stop stimulants. And truthfully, I may never stop opiates either unless I get a proper prescription. The fentanyl is so strong that prescribing people, 4 dilly 8s a day, or even upwards to 10 is not even going to even tip the boat. I know people that are upwards of 28 dilly 8s a day, and they're still feeling some withdrawal symptoms. The thing is now we need fentanyl. We need fentanyl patches. We need fentanyl prescriptions, because now even if we were to get, because we also have the prescription heroin program here, which only is 300 people, which is still though a lot of people. But the thing is that even people being titrated onto that are going through major withdrawal because the fentanyl is so much stronger. But we've been extremely lucky. But the thing is it's another thing that they're using as a tool. Until about 2 weeks ago, as of September 20th, they were going to take away the exemption of safe supply. So which means, so now not only are people on their opiate replacements, they're being prescribed 14 to 20 Dilaudid or Hydromorph or morphine a day, and then they could be taken away like that. That's not fair, because then now you're going to be responsible for putting people into extreme precipitated withdrawal symptom because you have decided to make a thing happen and then take a thing away. It's unfair and it's scary. I know that a lot of people are not even trying to access safe supply because of the fact of being scared of being taken off it. Because if you have to jump so many hoops to go through on an so for methadone, can you imagine what they're going through for a quote safe supply when it's actually being prescribed to you as an injectable replacement, as an injectable? So the doctor's prescribing it to you with full knowledge that that is something that you're going to use to inject. And then they prescribe, say, a generic brand, which is absolutely, you can inject it because it's a mess to do. Sometimes you can't even get it to, take it into a syringe, and that's what they're giving you as a safe supply, and it's not right. It's even here, we don't actually have the quote methadone, the original methadone formulation available to people unless you have a special exemption. I think we have 13 people in BC only on methadone because of, as of 2014, everybody was switched from methadone to methadose, which when 75 to 80% of the people that were switched either went up in their methadone scripts or relapsed back to heroin. So that means probably about 50% of those people are either dead or going to die.
Thank you so much, Laura, because
my screen might go out for a second, but just I need to answer something.
Yeah, no problem. Okay. So, thank you so much, Laura, because I think that you offer a perspective that complicates some of the solutions that we've been, really trying to think through here in the United States. I mean, as you can tell, things are far more restrictive here than they are up north. And even, there are many of us, and I'm sure that Louise would be happy to hop on right now, that still kind of see maybe some of these transitional steps, despite the fact that they're flawed, being, like a step in the right direction, a form of harm reduction for our current methadone policies. And maybe Louise, you and Helen could jump in for a second and just kind of speak about that, despite and because we are hearing some of the challenges, like still, what would you ideally like to see here in the States? And, what would look like progress for you?
Helen, you want to go first, or you want me to go? Okay. I can, anything would be progress. I mean, honest to God, Sheila, what we've got is so broken. What we've got is so broken and absolutely deadly that anything would be a move. Anything. I mean, a pharmacy-based system seems like a dream to me. Now, sure, when we get there, we have to, there's going to be problems along the way. Just because we know that there's problems with it doesn't mean we don't go that direction, right? That's how problems get fixed. We identify that we try something, we identify the problems, and we fucking fix them. That's just the way it works. We're not going to know until we try. What we know is we have rising overdose death rates. We have people dying at rates that are not okay. And we have a system that's broken. We have a medication that, however, is not broken. We have medication that works. And that is the sad part. So any way we can get the medication into the hands of the people that need it. I mean, at least what it would look like to me is if we could just access the damn medicine without all of the junk, right? And I know some people are saying, oh, but there's real, there's real problems. There's real this, you know what? Sure. There's a lot of reasons for a lot of things, but we've created these systems of like detective work we have created this need for like drug testing. This is all, what does it matter? Like, unless it's an abstinence-based system, like, why do you, like, I can't wrap my head around it. Like, An abstinence-based system calls for us to be abstinent, and then we are treated differently if we are abstinent. Why do it should be my behavior. It should always be my behavior, not the contents of my bloodstream or pee. Like, that is not the indicator of success for me. I showed up at this webinar. I show up where I'm supposed to show up pretty regularly and do what I'm supposed to do. I'm pretty good about doing that. Occasionally I miss some things. I'm disabled. I got lots of stuff going on, you know? Like, that should be the indicator of whether we trust me. That should be, you know, do I have a job? Do I show up? Do I do these things? Am I, you know, like, those are indicators of positive movement, not what you see on a drug screen. And to be quite frank, it makes everybody's jobs like ridiculous. We only are looking to see if I have a positive tox screen. If I do, then we don't listen to me, and I go unheard. And you know, I have a story about going to a clinic for a year, and I failed drug test the whole year. And after a year, they said, we're going to put you out. Yeah, you failed the drug test all year long, Louise. You can't pass one drug test. You got to go. Well, what they didn't know is during that year, I had left a fucking abusive relationship. I had gotten into graduate school. Like, all of these positive things were happening. And I was devastated the day I walked out of that clinic and they discharged me. And thank God I got into another, because when I walked out, I thought about killing myself. I didn't know what I was going to do. What was I going to do if I had to go back to using chaotically instead of at least having access? So when I think about what a treatment system is, that any fucking thing, anything but what we've got, any positive change, like, for real, like, we need to do something because people are dying.
Thank you so much, Louise, for sharing that. And I think that I speak on behalf of everyone on the call, and that it sounded like you were dealing with, you know, unlivable circumstances, and you were still reaching out for help. And I'm so sorry to hear that. I'd like to invite Helen to jump in, and then after your comment, Helen, we're going to open up to questions. We wanted to give our attendees the last chunk of time to ask questions to you all.
Yeah, I wanted to just put into the mix here something called administrative detox, where a person is essentially detoxed off of methadone because they can't pay. And that, I'm sorry, that should not be legal. That is absolutely unethical, but that happens all the time. I think we have to abolish methadone clinics, and there's just a couple quick reasons. They never should have been created in the first place. It's a huge mistake to have hundreds of people coming to one place to get methadone every single day. Louise has talked about some of them. It was a mistake in the beginning to create that kind of a system. The methadone clinic system, it embodies stigma. It's all about stigma. It's a separate place where those people go to get their medication. So methadone clinics embody stigma. You can't take it out of it because it's based on that. Related to that is NIMBY, not in my backyard. Every time a methadone clinic tries to open up, the community mobilizes to shut it down. It's like nothing mobilizes a community quicker. It's really sick than wanting to open up a methadone clinic in the midst of an opioid overdose crisis where this medication is so needed. So if you move to a pharmacy-based system, you get rid of NIMBY. So that right there is another huge reason that I believe we have to move to a pharmacy-based system. The other thing that I'm concerned about is because I think methadone clinics might try to do this to stave off abolition. They might try to make some major reforms. They might try to do that. No more talk screens, 14, 28-day take-homes right away instead of having to earn the privilege, the bottled privileges for years. They might try to do that. But here's the problem with that. Reforms can be taken away, right? 2-3 years down the line, and we have to think about this. We have to think strategically. 2-3 years down the line, you've got these great reforms, but something happens. Somebody overdoses and dies because they got 28 days of medication. Somebody, the DEA says there's massive diversion now, real or imagined, and the media gets a hold of it and whips up a drug panic. And then all of the reforms that made people's lives easier are then rolled back. We don't want a situation like that. If we move to a pharmacy-based situation, they cannot do that. So those are some of the reasons. The last thing I want to say, and because I know, again, some people on this call, they're going to say, hold on a minute. Some people cannot handle 14, 28 days. And I think that's true. Well, guess what? We can offer people the amount of days that they want to take home from a pharmacy. Let's think creatively, right? We're harm reductionists. The harm reduction community is one of the most creative groups of people I belong to, and they come up with all kinds of cutting edge solutions. So if somebody says to their provider, you know what, if I have 14 bottles at home, I might not do the right thing. Okay, how many do you think you can handle? 1, 2, 3, 4. We create services that center the patient, not an oppressive clinic system. So we have to think creatively when we move to a pharmacy-based system. And, you know, for Canada, I mean, you have to get rid of this observed ingestion. Part of my documentary was filmed in England, and they have the same thing. You start out, the pharmacist watches you take the medicine. No, wrong, stop. We're not doing that anymore. You come in once a month and you pick up your prescription and you walk the hell out. So in other countries, there's someone from Portugal on the call, Magda, and they have similar problems in Portugal. But those are better problems to have, right? It's better to have the problems of a pharmacy-based system than to have a clinic system that really, in so many ways, harms patients and leads to treatment trauma.
Thank you so much. So I'm going to pass the mic now to my colleague, Eliza Cohen, who is going to lead our facilitated Q&A because our question and answer box has been popping off the whole time, as has our chat box, and we want to give folks an opportunity to ask their questions. So Eliza, I will pass the mic to you.
Thanks so much, and thanks everyone for a great panel. I want to quickly go to Helen for a 20 or 30-second spiel on liquid handcuffs because tons of people are asking about it and if and where they can access it.
This will be really quick. I'm sorry, we're working on getting it onto some platforms so that people will be able to rent it, but we would love to show the film. My co-filmmaker, Marlena Marchetti, and I, we would love to show the film virtually and then have a talk back with people. So stay tuned.
Great, thank you. So we have a question that says, in the US, I hear a lot of physicians defend against methadone regulation as a protection against accidental methadone overdose. How do you all feel about that defense of US methadone regulation? Maybe Pooja, I'll go to you first.
Yeah, I think we have absolutely no evidence. I think this is so theoretical that for some reason, somebody will come in, receive their methadone, take too much, and overdose kind of independently, and that this is the whole reason that we need to directly observe therapy. I think that has never borne out. We've never had evidence of this, and we've never actually even tested whether or not this would be true. And I'm hopeful that with the pandemic, now that people are getting 14 and 28-day take-homes, we will be able to show that this idea of folks being at risk of overdosing with their home methadone is kind of crazy. I mean, I think the other kind of big issue for me when I think about it this way is that this is all around harm reduction. And at the end of the day, when somebody is seeking treatment with methadone, it's not because they can't receive something else that they could also overdose on. They're actively trying to get well. And so why, again, would we kind of punitively make them drink this medication, open their tongue, do this in the middle of like an open space for everybody to observe? One of the things that I always kind of drive home is that the only evidence that we have for directly observed therapy of any kind truly is in the sake of public health epidemics like tuberculosis, for example, where we do directly observe therapy. And that is not because we're worried about harm to the individual. It's because we're worried that if somebody doesn't take their medication, that this contagious disease will spread. Well, if somebody doesn't take their methadone, it doesn't spread to somebody else. And if they're going to overdose, they could have done it with another substance, and they're coming to receive treatment. So we should be respectful and empathetic towards that rather than being punitive when they come and get it.
Thank you. Does anyone else want to jump in before I move to the next question?
Yeah, I think people are more at risk of overdosing on illicit drugs or the tainted drug supply than they are of the prescription methadone. That is a mute argument. It doesn't work. It's not. That's a cop out. It's there because, like you said, if it needs be that an evidence-based system and the not giving cherries because of accidental death is not right. It's the illicit drug supply is tainted, which is what's killing.
Yeah, thank you both for that. We have a couple questions here about the different roles that state and federal governments play. So Helen, at the beginning, you talked about the DEA, but people have asked if we're successful on the federal level, we still have to combat the 50 states with total different views on methadone and drug treatment. What role do states play in the regulation and surveillance of methadone use?
Well, yeah, states can weigh in on methadone rules and regulations. So in some states, they really tighten up the regulations. For example, in some states, they don't allow 28 days. It's never possible to get a 28-day take home. I think that in order to abolish the methadone clinic system, we have to fight on a federal level. We have, a state-by-state strategy to me is not the way to go. The federal laws, I think, trump most state laws. So I think we have to take the fight directly to the federal government.
Thank you. We have a question from a pharmacist who runs an OUD and pain service, OUD and pain service in a family medicine clinic. They've had countless occasions to work with local methadone clinics and have tried to reach out, especially when patients are requesting to transfer to buprenorphine, either due to financial or transportation concerns. And in each of these instances, the methadone clinics refuse to speak to them or take information from them or collaborate on dose changes. Is this a trend you all have seen, and do you have any recommendations for this, for their unwillingness to engage in collaborative healthcare?
I think that there was a lot of federal regulation around data sharing and data safety in centers that treat individuals with substance use disorders. But a lot of these data safety concerns are often greater in our minds than in actuality, and they can be overcome. I think what happens, is we've been talking about a lot in this webinar, is that systems, methadone treatment programs come up with kind of pretty rigorous and rigid rules around how they can treat patients, who they can communicate with, and aren't really willing to see kind of the gray zone, in my opinion, on what a patient actually needs. And this flexibility is just not built into the system. And for some reason, every time a new program, sets up, the first thing they want to set up is the rigidity of these rules. And so I just think that at the end of the day, for some reason, we've created this pretty significant culture around being rigid and punitive in these treatment programs. And that extends not just to treatment, but also with respect to communication around other health problems or needs, or like our co-panelist said, or whether they need to travel for work or have other, life stressors going on. Just all of these things are just not, they're not honored.
Thank you. Does anyone else want to jump in? Great. So we've mentioned at a few points throughout this panel that we have seen some changes during the COVID-19 pandemic. they're not nearly enough. But we have a couple questions about what we anticipate seeing after the COVID pandemic has subsided a bit or is more under control. Do you anticipate any lasting changes, like the extended take homes, for example?
So that's the one thing that, you know, I think we're even seeking legal advice as it is, like as it stands right now, because like I said, so now we have our regulations and, you know, some of our changes have now been extended for a full year. So, you know, we have some time to try and work those things out. But that's the thing, is that, you know, there is a huge possibility that as soon as they quote seek that the pandemic is over or under control, that they can pull all these new implementations, which is wrong, because the thing is that pandemic or not, we needed these things anyways. We're still going to be dying when there's no pandemic. It's still going to be an illicit, a tainted drug market. Until these things are done, we're still going to die. So we're working on the way that the pandemic has added some things, but we still have to work for these things anyways. We've just been sorry, not to say it, I don't know how to say it right, but we're lucky for the pandemic that we've been able to actually speed through some of these things to get some of these things started. And that's the thing, is I think that the US needs to take heed from Canada, you know, on the things that we've already started, but also we cannot have a proper program, whether it's in a clinic or a pharmacy, unless it is peer attended, peer led, and peer developed. If it's not, it will never work properly, and people will still die, and there will still be a huge rate of dropout.
Yeah, thank you. Anyone else want to jump in before I move to the next question?
It's just worth repeating. It's just worth repeating. I just want to say it again. I put it in the chat box, and I just think, Laura, it's worth saying again so that people can hear. We cannot have a program that runs proper in Canada or the United States unless it's led and directed by people who are most affected. So, you know, and it's never going to work. So thank you, Laura.
I would just add one thing that I think would be super helpful to help keep these regulations from kind of becoming more rigid again after the pandemic. And one thing that we've struggled with is that every kind of treatment program is currently running independently, and it's incredibly hard because of the restrictions to gather the data on this, with respect to the fact that people probably are doing just fine with their take homes. And we've set up the system to kind of not allow us to gather that information in an effective way, so that we can then go back to the federal regulators and say, hey, look, this policy worked. There was very little harm caused by it, and we should keep it going. And so I would say on the advocacy level, for those of you who are advocates, I would, you know, ask for your treatment program to be transparent and to release that information to you, and to gather that information and assist in them gathering that information, because I don't think we are going to be able to keep these regulations going, because the first question the regulators are going to say is, well, was it safe? You know, did people have accidental overdoses? Did they, quote, divert their methadone? Like, those are going to be their questions. They're not going to care about the patient perspective whatsoever. But if we're not collecting that data and we can't prove it to them, then all it will take is one emotional argument about, oh no, I'm worried about an overdose, or oh no, I'm worried about somebody diverting their methadone, for it to go back to the way it was.
Can I jump in? Can I suggest something? I think it would be really awesome if maybe, you know, maybe with the Urban Drug Users Union, you could develop through different clinics your own survey or type research questions, and have them see if you can reach out to the other clinics and have a patient-based you know, made and use survey on how things are going for you, and then maybe see if you can find some either research students or something to try and help you to make this bigger, or maybe even try and connect with us and do one that's you know, together, because I know that we were working even actually, I think it might be with you, Louise, in your group there to do a survey on different things and
Yep, we got it.
if this works, because research-based treatments are great, and data-based information is a lot of times the only way that people will follow things. I might have to check out here in a minute early. I'm sorry if my computer goes.
No, we are working on that with you, Laura.
Okay, I thought so.
And we just had a survey where we had over 500 respondents, and
There we go. That's the one I'm talking about.
Right,
Cool.
so we're really excited about it.
Nice.
Laura, thank you so much for joining. Can you share your email address with folks in case they want to ask any follow-up questions after you hop off?
Sure. So it's just it's shaverlaura4@gmail.com. So just my first name, I mean my last name first, then my first name, and then the number 4, and it's at gmail.com. And I'd love to be on the computer, so I'd love to hear your comments, and talk to you later, guys.
Thanks so much, Laura.
Thanks. Helen, were you gonna jump in? Were you gonna say something?
I don't want to rain on the research parade, but I'm going to a little bit. I'm not opposed to this, but we know there's a long history of, you have all the research that shows, we had it with syringe exchange. So you can have that, and I'm not opposed to it, but the methadone clinic apparatus is entrenched, and it's going to take a movement, and we can use that research to be sure. But that in and of itself, right? We have that with a national healthcare system, a single payer system. We have tons of evidence. We still don't have that in the United States. So I want to put that out there to people, that is not going to be a magic solution that, oh, we get it now. We have this evidence and people didn't overdose and there wasn't diversion. It's going to take a movement to actually abolish the clinic system. But I do love research.
Helen, I totally agree. It has to be multifaceted, and research alone doesn't work, but research with advocates and policy change makers works together. And so it's all got to happen together. I would hate for us to miss this opportunity and only have one piece and be missing other pieces. So, like you've mentioned, it's going to take a movement. We've got to have all hands on deck.
Thank you. We still have tons of questions and unfortunately need to wrap up in a few minutes. So with that, I want to hand it back to Sheila to give some final remarks and let the panelists talk and close it out.
Yeah, so I thank you all for joining us today. We had record attendance for one of our Department of Research and Academic Engagement hosted events. Typically, these are humble but mighty gatherings of like-minded folks, and we are so thrilled that methadone brought all of us together today. And we were here to kind of talk about challenges and opportunities. And I think, I really do hope that folks who attended this panel learned a little bit more about some of the, the real promise and evidence supporting the use of methadone, the fact that people really do love their medication, want to take their medication, are committed to health and well-being, and see methadone as being part of that path towards healing and wellness. But unfortunately, a lot of our overly restrictive policies really limit access to this life-saving medication that obviously people want more access to and not less. And so before I kind of just wrap up, I wanted to just ask if each of you could just say 1 minute, one last, any closing remarks, anything that you have to say before I plug our events again, just as a reminder while I've got everyone on the line. Pooja, would you like to say any last words? 60 seconds.
Great. Well, I just want to say thank you for having me. I think that it's really great to have such a diverse group of individuals kind of talking about different perspectives and different potential solutions, and appreciate that the Drug Policy Alliance has combined us and that we can hopefully work together in creating a more just system.
Thank you. Louise, would you like to go next? Just 60 seconds, just kind of last thoughts?
Yeah, absolutely. Everything we do around methadone draws lots of people and lots of attention. And that's what I've seen lately, is that we get lots of people interested in doing something. If every person would do more, would do one step more than what they're doing. So don't just go to a webinar, do something beyond that. Do something, to take actual action and help us create real methadone reform, because, there's people's lives hanging in the balance. This will make the difference between people living and dying right now. If you know, it's the truth. Like, the regulations and the barriers of methadone stand in the way of people being alive. And it's one of the most important things we can do, and one of the least talked about until the pandemic, because nobody would talk about it. And so now we have people willing to talk about it. Let's do more than talk.
Thanks so much, Louise. 60 seconds, Helen.
Yeah, it's really tragic that it took a pandemic to open up this discussion about methadone and reforming or abolishing the system. But we have to take this unprecedented opportunity to do exactly that. And I believe that we are in a moment that we can fight and win a new system that is based in pharmacies, that gets rid of the stigma, that allows people to get their medications to be free, right? Because as long as we have this system, people on methadone are not free. And that's what it's about. It's about liberation. And I look forward to working with people to make that happen. It's long overdue. It's long overdue. And thank you, everybody, for coming to this webinar.
So yes, on behalf of the Drug Policy Alliance and Filter, we thank you so much for joining us. And just as a reminder, if you'd like to join us next week on Tuesday, we're hosting a webinar with the Global Drug Survey preliminary results around COVID-19 and changing drug market dynamics. And at the end of September, we will be hosting the book talk, Prison by Any Other Name, you know, a book about the challenges and the harmful consequences of what we call reform, and how many of our reforms are actually just pathways to incarceration and criminalization. So thank you all so much for joining us. Have a lovely rest of the day. Thank you, ladies. Thank you so much.